ممتاز. تشوفون نفس الشاشة صحيح؟
صحيح دكتور.
ايوه دكتور.
طيب. ممتاز. أول شيء السلام عليكم، أنا اسمي منصور الصالح، استشاري الطوارئ في مستشفى الملك خالد الجامعي جامعة الملك سعود. شوية الانتراكشن يكون أصعب إذا كان زوم، فإذا كان في أي سؤال أو استفسار بأي وقت ممكن تقاطعوني. أعتقد إنه التحضير دائما شيء أساسي عندكم، فيمكن عن طريق حنان إذا اكتمل العدد بس كابتشر سكرين الله يخليك الحضور، ويكون اسم الشخص مكتوب بحيث إذا طلبوها مني أرسلها له. تمام؟
أبشر دكتور.
الله يعافيك، تبشرين بالجنة. طيب هذه يمكن أهم محاضرة صراحة، لأنها general approach، ولأنه مثل ما تتخيلون there is no way to know interactions لكل toxicology في الحياة. لكن إذا عندنا general approach how to approach patient اللي يجي حتى لو كان undifferentiated, we just apply the same principles basically and hopefully save the patient. نبدأ بحالة طبعاً شوي صعب صراحة عن طريق زوم، لكن what I'm going to do I'll read the case, بعدين ودي أسمع منكم الأجوبة، عادي أي واحد يتكلم, and then we discuss it, consensus. So the first 25-year-old male present after ingestion of 20 tabs of paracetamol 1 hour ago. He's fully conscious, alert, vital signs are stable. Then what would be the next step? Induce vomiting, gastric lavage, activated charcoal will extract blood for investigation and send for liver at 4 hours. أي أحد يجاوب؟
gastric lavage.
charcoal. extract blood.
charcoal.
طيب اللي قالوا gastric lavage ليش gastric lavage؟
No, patient.
يعني كلامك منطقي، وأخذ شيء خلنا ننظف بطننا ونطلع. طيب gastric lavage would be almost في الوقت الحالي almost never is the right answer في كل شيء. يعني في exceptions بس overall it's rarely performed. طبعا induce vomiting مستحيل، يعني الفكرة انك يكون injured esophagus. Gastric lavage potentially في few cases. Activated charcoal it's not the right answer here, but activated charcoal it works by adsorbing الماتيريال, يعني just تشبك معاه deactivate it. بس as you can see mainly it makes sense in the first hour وإذا ما كان عندنا antidote. الميزة في الباراسيتامول although it's serious و concerning وعندنا محاضرة كاملة عنها, الميزة إنه we know if the antidote is given within the first 8 hours there is no injury, وعندنا excellent antidote. So basically why to do anything else? We just extract blood for investigation, send it for 4 hours. If the patient عنده toxic dose, then we just start the antidote. في exceptions, نعم, activated charcoal can be used with high doses of paracetamol if they present within the first hour. بس هذا already جاي على الحفة. The right answer here is extract blood for investigation and send for liver at 4 hours. طيب الكيس الثاني 16-year-old female present with significant decrease in liver consciousness after ingestion of a large amount of an epilepsy medication. She is unconscious. Blood pressure, but the blood pressure and heart rate are normal. What would be the next step? NGT or gastric lavage, intubate this patient, CT brain or IV fluids.
Intubate.
Okay, why intubate?
Because she is unconscious.
First step, I think we need to
secure airway.
To protect.
Yeah, so, exactly. So we want to protect. يعني تخيل معي إنه she ingested whatever significant amount of epilepsy medication. Now she's unconscious. What do you expect is going to happen further? Probably things will just get worse. You will work on doing certain investigations إلى آخره. وأنت بسم الله توك في بداية الموضوع. So intubate this patient, then you do everything else. Yes, you would intubate to protect the patient airway and be able to do the rest. اللي بعده 30-year-old history of depression, brought in for tonic-clonic seizure reported with benzo. The patient was intubated for airway protection due to significantly depressed level of consciousness. Blood pressure is soft, 100/60, heart rate is 160. What would be the next step? CT brain, EEG, ECG, tox screen.
ECG or
tox screen.
ليش ECG? You are right, بس ليش ECG?
عشان ال TCA overdose يكون في arrhythmia.
toxicology.
Yeah, so the point here, what is the investigation that I'm going to do at this point of time that will give me valuable information that may alter the patient course? تمام. A tox screen, it will take time for the result to come and very unlikely to change the patient course. EEG على ما يشبكون ايش يسمونها نسيت اسمها السلاك basically. And they do it. It will take a long time, so it's meaningless for the acute phase. You may need it down the road, but it's definitely not at the beginning. CT brain, again, very unlikely to give much information in such patients. You can do it, but it's not an immediate. But the ECG, it will give me valuable information. ولذلك we always say for any tox patients, ECG is a routine and to be done for everyone. So basically, what we look for mainly في التوكس لانه التوكس substance work on either blocking sodium channels which result in wide QRS ولا blocking potassium channel or result in long QT with some other manifestations في ECG for specific drugs مثل TCA. واحدة منكم قالت TCA و sometimes يكون في تداخل أكثر من شيء. For one, it will help me potentially to know what was the material اللي ingested مثل في حالة ال TCA and potentially treat the patient حتى لو ما أعرف وش كان عنده. لأن إذا كان عنده مثلا prolonged QT probably I'll give magnesium regardless. إذا كان عنده sodium prolonged QRS probably I'll give sodium which is through sodium bicarb regardless. ما يهمني كثير أعرف what did the patient take بس يهمني to treat the patient basically as soon as possible. طيب, so acute poisoning is a dynamic medical illness usually presenting an acute and potentially life-threatening exacerbation of a chronic underlying psychosocial disorder. Many of them underlying psychiatric disease, mental illness, depression, إلى آخره. These patients form a heterogeneous group that requires a systematic approach based on early resuscitation or risk assessment. Again, this is not complex. A systematic approach مثل general principles to be applied to emergency A, B, C, D على سبيل المثال. A systematic approach أي patient يجي regardless of what they ingested, what they claim they ingested first. مثلا they will go into a monitored bed. If they are sick, I'll start with resuscitation early. If they are not sick, I'll go and do a risk assessment. Classic example early resuscitation with risk assessment على سبيل المثال a patient أخذت high dose of paracetamol. أول 10 ساعات ولا حتى 20 ساعة patient may have nothing, mainly just nausea, vomiting, mild حتى. But we know in those patients, if they are not treated within the timeline, potentially they end up with liver failure. With liver failure, potentially they will end up with either transplant or death. So risk assessment here is very, very important. I want to catch those patients early to do the intervention required early to save this patient. Early resuscitation, the same. Patient, let's say, whatever the material they took. Their blood pressure is low, their heart rate is high, their ECG shows whatever. I'll just treat them. I يهمني كثير with what did the patient take في البداية. But then I'll start to gather information, put the picture together to conclude what did the patient take. So think about it. I want to have a systematic approach to approach any patient with potential tox ingestion, early resuscitation, and be aggressive with the resuscitation. Of course, risk assessment. Risk assessment, وش أخذت, متى أخذت, كم أخذت, إلى آخره. And then based on testing this against your medical knowledge, you would know, well, as ChatGPT, you would know what are the likelihood of this patient, becoming sick soon or not. And based on it, you would decide what intervention to be done. Pathophysiological toxic mechanisms, again, different. Local tissue damage, damage to the lung إذا كانت aspiration. It may stimulate or depress the CNS system or modulate the autonomous nervous system, basically. Blah, 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 إلى آخره. Overall mortality is low at 0.05%. That being said, the mortality rate of hospitalized patients was approximately 1 to 2%, which is quite relatively common. يعني account for 5 to 10% of all emergency department visits in terms of tox, or 5% of all ICU admissions. What's interesting, the most commonly implicated poisoning exposure due to analgesics. Paracetamol is definitely on the top of the list. For multiple reasons. الريزن الأول إنها متوفرة في أكثر من مكان, easily reachable. Two, إنها perceived as safe. يعني البنادول is extremely safe بالnormal doses. الحوامل يأخذون, everyone takes them, kids إلى آخره. بس extremely dangerous على higher doses. ف's potentially perceived, وهذه unfortunately many of the sad stories اللي نسمعها بسبب هالشيء. Young patient going through, depression or stressful event or whatever, and then they take it, part of it, let's say, seeking attention or just acting on a impulse, and then unfortunately they end up with with a liver failure, basically, which is basically a disaster. ولذلك حتى جزء منها as public health interventions, يعني لو تشوفون احيانا في الخارج when to go to Costco ولا Walmart ولا whatever, باراسيتامول ينباع كذا, خذ حبه في علبه فيها 100 حبه. It doesn't make sense حتى from a public health perspective. ولذلك البنادول عندنا ما ينباع بالعلب بالشكل هذا, لانه if you think about it, it's way more likely تحت impulse انك اذا كانت علبه كبيره just تفكها وتاخذ لك 15 20 حبه. بس اذا كنت تبي تفتح حبه زي البنادول اللي عندنا في السعوديه, تفتح الحبتين بعدين تفكر مره ثانيه بعدين مرتين بعدين, it's less likely to result in overdose. طيب, what's a toxidrome? احنا قلنا انه مو بدايم نعرف البيشنت وش اخذ. و at the end of the day كثير, يعني اذا قسمناها اخذنا كل التوكس في العالم, بالاخير فيها بعض التشابهات اللي ممكن potentially we group them into a distinct group or categories. Basically, a toxidrome means they are physical findings attributed to a specific class of toxins that can provide important clues to narrow the differential diagnosis. If we think about a classic example, على سبيل المثال, لو قلت لك patient Jack عنده pinpoint pupil, heart rate on the lower side, respiratory rate on the lower side, what's the most likely thing that they've ingested? Opioid. كيف استنتجت إنه opioid؟
البيوبل, then white pupils, respiratory decrease.
صحيح. So basically generalize الطريقة اللي فكرتي فيها في شيء كلاسيك مثل الأوبيويد على باقي substances. So this is basically what's a toxidrome. طبعا للأسف في موضوع الأوبيويد, يعني في الغرب it's a really big thing. يعني one of the most common causes of mortality for the young population. Multiple factors. بس يعني potentially the pandemic اللي عندهم, potentially to some extent it was unfortunately started by doctors. لأنه basically يجي أحد عنده chronic medical problem, let's say chronic back pain. Chronic back pain will never resolve acutely. It will need, it comes every now and then. بيحتاج إلى physiotherapy, بيحتاج إلى أشياء ثانية. we started giving them opioid. They got hooked up to it, يدمنونه, they get addicted, and then يقولوا sorry خلاص you're addicted, أنا ما أقدر أعطيك. they go into the street, يأخذونها من ال whatever illegal ways. Many of them are patches مضروبة جاية من الصين إلى آخره, synthetic fentanyls, end up with death لانه usually يكون متعود على دوز معينه، اخذ نفس الدوز بس هذا way more potent and they die. ولذلك وصلت مرحله انه النالوكزون اللي هو الانتيدوت is available in pharmacies. You go, you take it, no question asked. And then they encourage people انه if you are planning to take يعني to go higher or whatever, don't do it alone, do it with someone else, بحيث انه اذا لاحظ عليك شيء they will just give you naloxone. So but the message here طبعا الحمد لله عندنا السعوديه is limited. It's not easy just to prescribe opioid بسهوله. الان في منصه جديده اسمها منصه رقيب، ولذلك حتى لو راح المريض للمستشفى اكس بعدين طلع راح المستشفى واي بعدين مربوط، ف they would know there is a suspicious behavior, just تروح المنصه رقيب and you know if opioid were dispensed or not. Unfortunately those sad stories still موجوده في السعوديه way significantly smaller scale طبعا عن اللي يصير خارجيا، بس unfortunately we see it حتى يعني even sometimes we hear about stories in the medical field. So just keep in mind, when opioid is required you prescribe it. Patient عنده fracture they only need a couple of days of opioid. Yes. رايح عملية yes. But don't prescribe it for chronic issues. And you are not solving the problem. Chronic issue being back pain, the classic example. So always keep this in mind. طيب التوكسيدروم أول شيء أي سؤال so far؟
لا واضح دكتور يعطيك العافية.
تمام. So toxidromes, classic toxidrome sympathetomimetic. Sympathetomimetic مثل الشبو، مثل الكوكين، مثل الأمفيتامين إلى آخره. This is a sympathetomimetic. And the patient become hyper alert, agitated, hallucination, sometimes paranoia. The pupils of combined biases. They are coming in the fight or flight mode. تشبهها مرة الانتيكولينرجيك توكسيدروم. يتشابهون بسيمتومز كثير، بس الفرق الأساسي بينهم إنه في الانتيكولينرجيك they have dry flushed skin, while في sympathetomimetic actually they are diaphoretic. So this is one of the classic differentiation between those two. ثالثة cholinergic toxidrome. الكولينرجيك طبعا بتكون عكس الانتيكولينرجيك. A classic example for cholinergic now صايرة أقل عندنا، لكنها كلاسيك اكزامبل خصوصا كان في السابق الاورجانوفوسفيت بويزنينج. الاورجانوفوسفيت بويزنينج هو اللي يستخدم في كمبيد حشري، وكان ينباع يعني easily accessible، ولذلك كان في حالات unfortunately كثيره whether intentional or non-intentional. intentional as suicide, non-intentional as أطفال ولا حتى مزارعين whatever they didn't يعني take the enough precautions and they come with a cholinergic toxidrome. Classic manifestation, salivation, urinary incontinence, like fluid from everywhere. Urinary incontinence, diaphoresis, diarrhea, emesis, diaphoresis, lacrimation إلى آخره. هذه الكولينرجيك. Then والأوبيويد يمكن تكلمنا عنها شوي. بعدها السيداتيف هيبنوتيك. والكلاسيك اكزامبلز هنا البنزو والالكحول. Overall it's يعني benzo is relative. It's a safe medication, but unless high dose, extremely high dose to reach respiratory depression, then we have a problem. Otherwise, overall, it's okay. It's a safe medication, and we use it quite generously for emergency to control agitation. بس طبعا addictive. People get addicted to it. It's similar to alcohol. When it's used for a long time, it cannot be just stopped abruptly. Then if it's stopped abruptly, it may result in seizure. Then withdrawal toxidrome, it's basically عكس التوكسيدروم نفسه usually in terms of symptoms. وفي categories as a withdrawal deadly, وفي categories are unpleasant but not deadly. فعلى سبيل المثال لو جبت أحد على أوبيويد ولا حشيش ولا whatever ومنعتهم and they are يعني chronic users ومنعتهم حطيتها في غرفة قفلت عليها they will not die. It's very extremely unpleasant but they will not die. في المقابل if someone on a long dose يعني heavy long term use of alcohol ولا benzo no, actually they may die if you just abruptly stopped it. It has to be treated under medical supervision. You cannot just go كذا cold turkey whatever. طبعا those usually heavy long duration. فهذا basically withdrawal. هذا الانتيكولينرجيك والسمباثوميمتيك تكلمنا عنها، تتشابه في اشياء كثيره، بس the main differentiator is the skin. It's a dry الانتيكولينرجيك, quiet diaphoretic في السمباثوميمتيك. هذا الكلاسيك example في الأوبيويد toxicity. And again we touched on this. An important piece of information to know here اللي هو الانتيدوت. الانتيدوت is naloxone. زي ما قلت لكم برا يعطى حتى في الصيدليات, no question asked. Important aspect هنا إنه to know إنه naloxone half life is I think it's around, our action is 40-ish minutes. But some opioids are actually longer duration. But repeated dosing may be needed ولا حتى infusions. This is classic في again synthetic fentanyl. الباتشز اللي تجي من الصين usually is long acting, or usually the people need IV trip, ICU admission إلى آخره. وسometimes حتى في unfortunate cases يعني نذكر during residency كان في بالخطأ high dose of opioid كان اسمه dilaudid was given to a patient بالخطأ, and then it was picked by the nurse naloxone was given. But unfortunately خلاص everyone is happy, الحمد لله أمورنا زينة. They came back like an hour to check on the patient is dead. Basically simply because the duration, half-life of the opioid is longer than the naloxone. And to give a naloxone, you reverse it, everything is fine. But guess what? In 40-50 minutes of that, it kicked in again. And unfortunately, the patient died. So always think about this. Sympathomimetic, again, one of the classic examples of Saudi is shabu, which is part of an amphetamine. And they come fight or flight mode, and sometimes quite agitated, paranoia إلى آخره. Management, agitation, يعني basically it supports the treatment. So you give them just generous doses of benzodiazepine, midazolam, lorazepam, whatever, to calm them down. طبعا we always say that the general rules have many exceptions, and polydrug overdoses may result in overlapping and confusing mixed syndromes. لأن الأشياء اللي went through it earlier بس التوكسيتروم أنت أخذت كذا وتنتوقع أن يصير عندك الفايندينجز هذه. طيب لو أخذت الشيء ضد إيش راح يصير؟ لو أخذت شيء وأخذت شيء ثاني delayed absorption إيش راح يصير؟ So polydrug may complicate the picture. Or mask certain features. So this is something also to be kept in mind. The general approach, again, start with resuscitation. Go through your physical examination. Again, physical examination, all what you need is your vital signs. And then there are certain things that potentially specific for tox. فعلى سبيل المثال, are they sweaty or not? Just wear a gloves, حطه تحت الarmpit, you will get your answer if they're dry or sweat. كانوا يقولون على الباول sound, but I'm not sure about bowel sound, how is that always accurate or not. You can also check for, of course, you will examine the eyes, إذا كان عندهم pinpoint, dilated, nystagmus إلى آخره. Check for clonus. أتوقع كلكم يعرفون how to check for clonus. So basically check for clonus as well, and في certain groups can result in clonus مثل SSRI toxicity. Then you will do your risk assessment, history, كم متى أخذت وش أخذت إلى آخره. Send for investigations when appropriate. إذا كان في room for decontamination, do it. You will give an antidote, supportive therapy, and then dispo. Always for resuscitation, think that initial assessment and treatment should target potential life-threatening situations or occur inappropriately staffed and equipped resuscitation area. Always start high and then downgrade raise relax. Think about extended ABC approach. Of course, have a low threshold for intubation. Vital signs. And the vital signs gives you clues. إذا كان عندك subtle hyperthermia, subtle tachypnea, all of this can give you hints. of what's going on. To consider intubation طبعا إذا كان عندك depressed level of consciousness, كان عندك severe acidosis, respiratory failure, or there can be risk of aspiration, مثل if you plan to do a gastric lavage, which is again less likely to be done. لكن of course if you're going to do a gastric lavage, you cannot do it while the patient is not intubated. Detect those conditions early to treat it. Seizure, hypoglycemia, hypothermia إلى آخره لأنهم it can be easily treated and it's excellent supportive therapy. وإذا كان في لا سمح الله cardiac arrest, resuscitation should be prolonged. والسبب simply because one, many of those are actually young and healthy patients. So they have excellent reserves. بعكس elderly who's coming with a heart attack and they are 85 years old على سبيل المثال. And two, actually they went into cardiac arrest because a substance that they took. So the thinking is if I reverse or neutralize the substance, you know what, those patients may survive and do pretty well. So in general, in tox cases with cardiac arrest, we tend to often prolong the resuscitation efforts before calling it off. Examination, we went through this. ويمكن هذه صورة تلخص what we went through. Agents affecting the pupil size, again, في classic things مثل opioid, you know, أحيانا في أشياء ثانية تتشابه معها. الريسك assessment, again, وش أخذت، متى أخذت، كم هبة، متى أخذت، what's the current clinical status, وإذا كان في any specific patient factors, elderly غير عن young إلى آخره. Underlying chronic medical problem وبعد reserve versus healthy good reserve. It just gives you a sense where are we going with this patient. Investigations, يعني probably what will give you real information or add value is the routine investigations اللي هو random blood glucose, electrolytes إلى آخره. And those are actually more useful than toxicology screens. The tox screen في urine و blood. طبعا الurine usually in general able to test for 6 substances. Classically في emergency we are not excited about those لأنه false positive is there, false negative is there. Maybe the patient, you know, I don't know, patient يحشش لفترة بس has nothing to do with his presentation today. It's not going to change much and it will take time to come. ولذلك usually we are not enthusiastic about them. However, sometimes few exceptions with the pediatrics, it is an exception. لكن sometimes we do it because our colleague with psychiatry they need it. So sometimes we do it. For blood, the same. Maybe the blood, the most important one is acetaminophen, paracetamol. We send it for everyone. Then it's very important and quantifiable, and we can do something about it. But that's the usual classic blood test we send. Others, مثل aspirin, we can send it. Alcohol level, we can send it. But again, aspirin helpful, but otherwise it's probably of limited value. لأن الأشياء أصلاً إذا أنت بترسل شيء مجاك بعد يومين ولا 3 أيام there is no point. مثلا methanol takes what 2-3 days to be tested. By that time, if the patient is sick, the patient is dead. So you have to act with the information. قلنا ECG is a must. Chest X-ray that can be aspiration pneumonia. Abdominal X-ray sometimes is helpful in screening for ingestion of radiopaque materials. قلنا ECG paracetamol level should be part of routine testing for everyone. ECG can help with diagnostic and prognostic information. Urine tox does not add much. واحدة منكم قالت عن TCA. So yes, ECG is helpful لأنه in this patient لو قلنا هذا patient عمره I don't know 25 years old. Does it look normal? No, it doesn't look normal. Why? لأنه simple terms على سبيل المثال هذا اللي في النص اللي اسمه QRS is actually big. This is not normal QRS. This is a wide QRS. ما أقدر أشوف وين ال T تنتهي وين ال P تبدأ. عنده prolonged QT this patient. It looks fast عنده tachycardia and then the shape of the AVR في notch كذا في lead AVR all of this points into TCA toxicity. What I'm going to do, so basically such patient كده من البداية just give them sodium bicarb, sodium bicarb, sodium bicarb. شفت ال ECG وسمعت إنه history of tox, I'll just give it. I don't need much information now. Let me resuscitate, stabilize the patient. And it doesn't matter هو ماخذ TCA toxicity ولا extremely high dose of I don't know Benadryl ولا cocaine. Benadryl اللي هو diphenhydramine ولا cocaine اللي فيها some sort of sodium channel blockade. بالأخير same treatment. هذا جدول يلخص بعض الفايندينجز في الECG للتوكس. و always calculate the anion gap لأن الanion gap فيها ميزة يعني في 1000 مليون نيمونيك في الطب بعدين تفكر بنيمونيك for a mnemonic but when in reality only few mnemonics really matter. واحدة منهم اللي هو causes of high anion gap metabolic acidosis لأن when you calculate the anion gap طلعت high again anion gap is ما أدري أنتوا المحاضرة كان المفروض اليوم مع الدكتور سقي بس تأجلت أعتقد بس الانيون جاب basically is صوديوم ناقص الكلورايد ناقص البايكارب. إذا كانت أكثر من 12 نعتبرها high anion gap metabolic acidosis. So sodium minus chloride minus bicarb. More than 12 is abnormal. والميزة إن عندي نيمونيك ولازم لازم الكوز is one of those. ما نقدر نطلع منه. So it does make sense. ولذلك is very important. طبعا هذا مبحبحينها شويه مزودين اشياء لكنه بالاخير this is the differential diagnosis of high anion gap metabolic acidosis and I think it's an important mnemonic for you to remember for the rest of your medical career لأنها it simplify things for you. Decontamination, again, the sooner decontamination is performed, the more effective it is at preventing continued poisoning absorption. مثلا الجاي على يعني whatever they get exposed to chemical على their clothes, just remove the clothes, otherwise it will be continuous absorption. جاء شيء على عينه, start irrigation immediately, just to remove it, to decontaminate it, because otherwise it will just get absorbed and cause more problems. طيب skin again شيل الملابس decontaminate by water. eyes تكلمنا عنها. تكلمنا عن activated charcoal. Activated charcoal again it works by adsorbing مو absorbing adsorbing a chemical, so it just get connected مو connected get تشبك ب toxic material and then just leaves the body. And as you can imagine, it's usually in the first 1 hour, but sometimes we get a bit further down the road. المهم هنا the patient should be alert, متعاون معك, لأن the last thing you want to give them activated charcoal and they are semi-unconscious, then they vomit, and then they end up with aspiration pneumonia. If they are drowsy or unconscious, just intubate them and then give them the activated charcoal. And then في certain substances that ما تشبك بالactivated charcoal. A classic example, heavy metals, lithium, iron إلى آخره, والpesticide were basically solvents. gastric lavage تكلمنا عنها earlier. Should only be considered the patient presenting a toxic lethal dose in the first hour after exposure with protected airway. وحتى هنا يقول لك within an hour حسب الأمريكان Association of Poison Centers, within an hour of ingestion of a potentially life-threatening poison which does not adsorb to activated charcoal or for which no antidote exists, and even then in a center with sufficient expertise. I don't recall متى آخر مرة صراحة شفتها performed in real patients. whole bowel irrigation يستخدم البوليإيثايلين glycol اللي هو يستخدم في نفس المادة اللي تستخدم في preparation for colonoscopies. Basically you give 1 to 4 liters per hour until the patient passes clear fluid from the bowel. وهذه مثلا تنفع في body packer على سبيل المثال اللي هم يهربون بحدود whatever cocaine whatever. Sometimes helpful, ولا حتى في الايرون sometimes. gets stuck في الباول and you just give it. Enhanced elimination مثل dialysis. So في certain materials are dialysable toxins, and for it to be dialysable لازم تكون high water solubility, low protein binding, low molecular weight. So basically it's available to be dialysable. تخيل شيء has low water solubility ولا it's binding very heavily مع البروتينز, quite difficult to dialyze those substances. وهذا basically the dialysable toxins. يمكن what's relevant في practice more هنا salicylate اللي هو الاسبرين, وطبعا الميثانول toxicity, لانه الميثانول sometimes الخليج بدي يصير في pandemic or whatever كذا cluster of cases. Unfortunately, given the nature of it, usually يصير في multiple cases. تجي كذا multiple cases. Unfortunately, if it's not treated, it results in permanent damage and death. Recently, الظاهر كان قبل كم شهر في الكويت big series of cases, many of them died. كانوا أغلبهم آسيويين. Usually يكون alcohol مغشوش basically.
دكتور هو الفيك الكحول؟
هو الفيك الكحول. طبعا المفروض اصلا الميثانول المفروض حتى ما يستخدم في الكالونيا حتى. يعني الكالونيا مثلا المفروض ما يستخدم الميثانول to start with. بس بما انه cheaper في البرودكشن فبيسكلي احيانا يستخدم. it result in a methanol either اللي يصنعون they want to save money basically or things goes wrong. في يكون local production of alcohol and then just things goes wrong would end up being methanol. People get confused, they use it, they assume انه alcohol أصلي وبالأخير they start to have unfortunately methanol toxicity. Unfortunately is a big, يعني it's something that we see in practice. We don't hear of. Unfortunately it's there. So always you cannot test it في البداية. You check for high anion gap metabolic acidosis or high osmolality gap, and then just based on the assumption, you just treat it. You don't wait, because if you wait, it's a problem.
You treat it مع العكس صح؟ مع الريل
الإيثانول مع الإيثانول صح؟
يعني
الألكحول درينك صح؟
إذا أنت في in the middle of nowhere في جبال الهيمالايا ولا جبال whatever, yes, you treat it with alcohol. لأنه basically what alcohol does is they compete on the same enzyme. So it delay the absorption. طبعا المشكلة في الميثانول not methanol itself. المشكلة في الميثانول الباي product of methanol اللي هو بعد الميتابوليزم. So you want to prevent the metabolism. So when you give them real alcohol اللي هو ethanol, they compete on the same enzyme. فيصير metabolism للgood alcohol basically. والباد alcohol اللي هو الميثانول ما يصير له metabolism. It gets really delayed. So that's the reason they protect it. بس في الحقيقة we don't use alcohol. في الحقيقة use في antidote اسمه fomepizole. So we use it because it's more potent. Would result in reverse. It's more potent definitely in treating the case. And if the patient is sicker, actually, we do dialysis for those patients. So yes, alcohol يعتبر إيثانول عفوا يعتبر antidote. بس في أرض الواقع في المستشفيات we don't use alcohol. We use fomepizole. طيب قلنا الانتيدوت dramatically reduce morbidity and mortality. They work in different ways وهذه لسته basically selected antidotes. شوفي هذه مثلا الفوميبازول ولا ايثانول للميثانول والايثايلين جلايكول as an antidote. طبعا الناك عندنا محاضرة كاملة عنه next lecture للاسيتامينوفين. oxygen hyperbarics والكربون مونوكسيد نالوكسون واللسته. intravenous fat emulsion. يعني الكونسبت هنا انه اذا كان السبستانس is lipophilic dissolve ولا تشبك مع الليبيد, فif we give them lipid maybe we can prevent toxicity منها. A classic example is شو اسمه local anesthesia, lidocaine, bupivacaine إلى آخره. But then they tried it in other things. Sometimes it works, sometimes it's not. بس هذه واحدة من الأشياء تستخدم. Supportive care تكلمنا عنه. Agitated behavior قلنا benzo to control the agitation of the patient. Dispo, patients who develop only mild toxicity and who have only predicted. Yeah, anyhow, if they are sick, they go inside. If they are not, they get 4 to 6 hours of observation, and then they can leave. بعدين patient with moderate إلى آخره أتكلم عنه. هذا summary. طيب, any question?
clear دكتور.
أكيد. طيب.
إيه.
ممتاز. خليني أفتح باقي المحاضرات. المحاضرة الثانية شوي بعد هيفي. هذه أطولهم. بعدين شوي هيفي acetaminophen. بعدين الأخيرات سهلات. I have to finish before 3. تبون 5 minutes break ولا تبون نكملوا بس؟
نكمل.
نكمل.
تمام. خليني بس أفتح باقي المحاضرة.